Welcome back, everyone, to part 2 of the PET in Oncology lecture PowerPoint series. We're just going to pick up where we left off from part 1. Part 1 concentrated mostly on the protocols and the preparation of the patient. And part 2, we'll start off looking at some of the indications for doing PET-CT. So you can see from this list that there are a number of tumors that are FDG avid, and for those reasons, we can use PET-CT to investigate either the initial diagnosis or the follow-up of these particular types of tumors. You'll notice as well that there is a fair amount of research that is always ongoing here and around the world. So there's always going to be new applications of PET, particularly with FDG, as we learn more about its applications in oncology. So the other thing to notice is that there are a number of common tumors that are not actually FDG avid. In which case FDG would not routinely be used to image these types of tumors. It doesn't necessarily mean that PET cannot be utilized. So, for example, with prostate cancer, we now have gallium-68 PSMA. For carcinoid tumors, we have dotatate and DOTATOC. For some of the neuroendocrine tumors, we have a new agent, fluorine-18, AMBF3.Tate. They're doing some clinical trials using that. Also, FDOPA is in clinical trials at BC Cancer as well. So this is the list of approved indications for PET CT using FDG at BC Cancer. I probably don't expect you to memorize this list, but you certainly should be familiar with the types of tumors that can routinely be studied using FDG PET. Sorry, I'm hoping my voice lasts. This is about my 6th hour of lecturing and recording. So the common rationale for performing PET at BC Cancer Agency in conjunction with BC Children's Hospital includes using it for staging, restaging, and metastatic workup, to assess response, to assist in biopsy site planning. It can be used as well for treatment planning. They often will scan patients in PET-CT using the immobilization molds that will eventually be used to do the radiation treatment in these patients. And so they can combine the information from the PET-CT and use that when they're irradiating the patient. PET can also be used for end of therapy baselines. It confirms discrepant findings on other types of imaging studies, and it can also be used for screening for second malignancy. These are some of the common pediatric tumors that can be evaluated at BC Cancer, so a long list of them. Many of these used to be scanned just in the regular nuclear medicine department, and the protocols have changed because there's greater sensitivity and sometimes specificity using some of the PET agents. So a prime example of that would be, the sarcomas, the osteogenic and Ewing's sarcomas that we still do bone scans on them, but we used to use thallium to evaluate treatment response, and now we can use PET. Neuroblastomas, we traditionally use MIBG, but sometimes MIBG is equivocal or even negative, in which case a PET may be useful. those are probably the more common applications in pediatrics. BC Children's has a number of reserved time slots for their patients, usually 1 to 2 days per week. Ideally, it'd be nice if we had a dedicated scanner for peds, but again, resources are scarce in the province. So for the time being, we share the scanner with BC Cancer. So one of the concerns in PET, of course, is radiation safety, and PET technologists have increased exposure from handling high activity of the high energy photons, in addition to having close proximity to the injected patients. PET patients may emit Compton scattered photons with a mean energy of 200 to 300 keV, which, as you know, is significantly higher than traditional nuclear medicine departments, where we're using technetium with an energy of 140 keV. So ALARA is particularly crucial to reducing radiation exposure, and they take radiation safety very seriously at PET, to the point where they actually have their own radiation safety officer on site. So how do we manage exposure in PET? The first modification, of course, is shielding. So a 511 keV photon has a half value layer of 4 millimeters of lead. The syringe shields are made from tungsten, which is almost 1.5 times as effective as the same thickness of lead. And the lead glass viewing windows in the control room and such are made of 4-inch thick lead glass. As you know from our tour as well, they have very thick concrete walls that help to shield the cyclotron. In terms of distance, they make sure they use tongs. They have remote manipulators that they use whenever possible when they're handling the vials, the syringes, and the sources. They recently purchased an auto injector, which I'll show you some pictures of on the next slide. And that is hope that will help reduce some of their exposure as well. And then time, obviously working quickly, but safely, and trying to minimize time with the patient. Remember that we allow the patient to ask questions before they're injected, so that once they are radioactive, we don't have to spend a lot of time in close proximity to them, trying to explain or answer their questions. Interestingly, Tina, one of the techs at PET, she just presented a paper, I believe maybe 2 years ago. They were doing some research on the doses that they were receiving to their hands from manipulating the sources. And they thought that they were getting high doses to their dominant hand, which in most people is their right hand. But when they actually did the research, they were surprised to find that their left hand actually was receiving more dose than the right hand. And that was because the left hand was usually holding the pig that had the radiation in it. And so they've since made some changes in their setup, and they have a device that sort of holds the pig for them so that they can minimize their exposure. Oh, sorry, I didn't paste the auto injector into this presentation. Hold on 1 second. Sorry for that little interruption. I was working off of 2 different PowerPoints on my screens. So this is a picture of what an auto injector looks like it's just one type of model. I believe this is the one they've got at PET, and this is all lead lined, and this is sort of what it looks like inside. And basically, you can program, the dose or the volume that you want to administer to the patient, and you hook up their IV tubing, and it will inject for you. So that you don't have to be handling the doses on the syringes. Here's the website here. If any of you are interested, you can go on, and this is actually a video that shows you, how to set it up and how it works. Some of you may have already learned this if you've gone for your PET rotations. Okay, so let's talk a little bit about a typical imaging protocol. So again, in terms of the patient, fasting 4 to 6 hours, making sure that their blood glucose levels are good, and then we inject the tracer, have them in a nice warm room, sitting nice and quietly, and then we scan them 60 plus or minus 2 minutes later. When they get the patient onto the bed, the first thing they do is the CT. They do the scout or the topogram, and then they do the quick CT scan, and then they begin the PET study. The scan time will be based on the time per bed position. So these are just guidelines for brain, about 10 minutes. For the scan, a heart, 10 minutes. Whole body takes a little bit longer, 20 minutes. The number of bed positions is going to be dependent on the patient height, as also dependent on the history. In other words, where is the tumor located, and what length of the patient would you have to image. Just of note that there was a new whole body scanner introduced in 2019. It was unveiled at the SNMMI meeting, I believe, last year, and it's been developed by a company called United Imaging. So it was pretty cool. Again, I thought I had put a slide in to show you it, but I'll post the link on the Learning Hub for you. So this image just shows you what a normal PET-CT scan would look like. So you've got your CT here, you've got your PET scan here, and then this is the fused image. And so, there is value in having the fused images so that we have more precise anatomic localization. For the most part, PET is always done in conjunction with CT, which is a little bit different than SPECT, where sometimes we do CT and sometimes we don't. But the vast majority of PET scans are done exclusively with CT. So what does a normal whole body look like in terms of the FDG uptake? So you notice that I've got two categories: the common sites of uptake and then sites that have variable activity. So if we look first at the common sites, these are sites that will almost invariably have moderate to intense uptake, right? So you can see the brain, right? Most of us utilizing lots of glucose in our brains, hopefully. The heart, right, which also utilizes a lot of glucose. So it's usually a moderate to intense, although it can be slightly variable, but we almost always will see heart on the FDG scan. Liver, you can see the outline of the liver here. The kidneys are well defined, particularly the renal calyces and the renal pelvis. And then, of course, the bladder, right, is usually quite intense. In terms of the sites that have variable activity, these sites can have anywhere from low to mild to relatively moderate uptake. So you should have a general appreciation for which organs we were likely to see, which are likely to have fairly intense, moderate to intense uptake in them, and which are would have variable uptake. With the ones that have variable uptake, we're not, the uptake should be relatively uniform in these tissues, and we're not too concerned if, in one patient the thyroid is hotter than in another patient. However, if there is a focal uptake in any of these organs, then it has to be investigated as a possible malignancy. Okay? But if it's just sort of uniform and variable and diffuse, then we don't get too concerned. In contrast, here's an example of an abnormal PET-CT scan. You can see there's multiple lesions throughout the liver, maybe one, I'm not sure where this is, maybe a inguinal node, perhaps, and then something up here in the chest as well. Hard to say exactly where that is without looking at some reconstructed images, but there definitely are a number of focal lesions on this scan, and the fused image does help us localize the uptake a little bit more precisely. So this is just an example that demonstrates how PET-CT can enhance detection of lesions. This was a 47-year-old male with biopsy-proven recurrent thyroid cancer. He's now 3 months post-thyroidectomy, comes for an I-131 scan, and, from all accounts, looks pretty clear, looks pretty normal, right? We get some normal stomach and bowel, bladder, right? But certainly in the thyroid bed, there doesn't look to be any residual activity. He came then for a PET scan, and you can see that indeed there are multiple foci of increased uptake on the FDG scan. So he obviously has some recurrent disease that was not seen on the I-131 test. So why the discrepancy? Maybe whatever tumor he had low avidity for iodine, or perhaps it's due to the poor imaging characteristics of I-131. Any of you that have done an I-131 whole body know that the images aren't the greatest resolution. I-131 has high energy photons, and our gamma cameras have decreased efficiency of detection for the higher energy photons. Their crystal thickness is probably a bit thin for the high energy of I-131. So those various factors may contribute to the fact that we don't see this uptake on the I-131, and yet it is very clearly intense on the FDG PET. Here's another example of enhanced detection localization. The PET study showed that the patient had a number of abnormal lesions in their body. This was a patient with a melanoma in the right axilla that had been removed. You can see that there's still some uptake in the axilla. There also is some uptake in the cervical area, maybe cervical nodes. And then there's also this little spot down here in the proximal right femur. And there may also be some nodes in the axillary region as well. So again, PET is able to identify a number of abnormal lesions throughout the body that that may have been missed otherwise. PET can be used for monitoring response to treatment. This is a 63-year-old male, stage 3A lung cancer, who had received 4 cycles of chemotherapy. This is his PET scan before treatment. You can see quite intense uptake in this lung lesion. After his chemo, though, you can see that the lesion has shrunken significantly. So certainly size-wise, the lesion has decreased in size, but just as important is that the SUV value has decreased significantly, and this is compatible with a favorable response to treatment. So another example, this time with a non-Hodgkin's lymphoma, where the PET scan is able to demonstrate response to therapy. This is the patient's initial baseline study, and you can see massive involvement here up in the axillary area, throughout the bowel. So quite bulky tumor mass. 1 week post-induction therapy, they decided to repeat the study to see, I suppose, if the chemotherapy was having any effect, and indeed it has. While there's still a lot of disease up here, I think you can appreciate that it is decreased in size, and there's marked reduction of activity throughout the bowel. Now, I'll just say that it's rare that they would order a scan just 1 week post therapy. But in this particular case, I guess they wanted to see what kind of a result or response the patient was having, because obviously he had quite bulky disease here. But the PET scan is quite valuable in demonstrating this positive response to therapy. This is an example of a Ewing's tumor. These are MRIs. So this is the pre on the top, right? 2 different sequences, right? This is the PET scan pre, and then this is post, right? So a couple of things to notice. On the PET scan, you can see that we go from this very intense uptake before treatment to almost negligible uptake on the follow-up scan. So this is a really good response to treatment. Now on the MR, you can see there has been some change in the size of the tumor, but there's still a lot of this residual uptake on the MRI. And the question always is this necrotic debris? Is this scarring? Or is this tumor that is still active, right? And it's hard to know because MRI is just an anatomic imaging modality. There's no physiology involved, right? So this could, if they went based on this, they might say, well, yes, the tumor has shrunk, but it's still there, right? It's still actively growing. Whereas when we look at the PET scan, it's quite clear that the tumor response has been quite remarkable. Yet another example here. This is a 11-year-old male hepatoblastoma. This is his initial scan, and you can see he's got a number of lesions throughout the abdomen, pelvis, other areas in the skeleton. And after 1 cycle of chemotherapy, you can see there's been marked improvement in his scan. So this gives them an idea of, whether the chemotherapy is working and is able to direct the appropriate treatment for the patient. Okay, so I want to talk a little bit about some of the common problems and pitfalls that can occur with PET imaging. I do refer you to the article in the Learning Hub. There's a couple of them on FDG imaging, pitfalls and artifacts, and then there's another one, pitfalls and artifacts, in the use of PET-CT and oncology imaging. I believe a few of these are relatively long articles, although I do recommend that you try to read them because they've got some good information that will supplement this note package. If you are short on time, what I suggest is that you concentrate on looking at some of the images in the articles. They've got some really nice case studies and images. They are best viewed on the Learning Hub digitally, just because the images project a little bit better than if you try to print them out. So what are some causes of false negative and false positive scans? False negative findings, so this is if we say that there's no tumor, and the patient actually does have a tumor present. So sometimes this can be related to tumor histology. So for example, CNS tumors may be hard to see because there's intense physiologic brain uptake of the FDG, right? So it's just very difficult for us to detect, a hot lesion within a hot background. Sometimes we get false negative studies in diabetics, again, the effects of insulin and metformin, or in patients that are not fasting. This can result in uptake in muscle and bowel, and that may end up masking potential lesions in the abdomen. And then there are some just physical limitations of our equipment. So while PET has better resolution than SPECT, there are still limits. And so lesions that are less than 5 to 8 millimeters may be difficult to see. And the resolution obviously is going to depend on the age and the capability of the PET scanner. So here's an example of a false negative study. This was a patient who had high levels of insulin. We don't know why. It could be that he was given insulin or took some insulin prior to the test, or maybe he wasn't fasting. But regardless, he has a lot of muscle uptake, right? You can see it here, right? You can see it up in here, right? In the chest area, right? Probably from, just normal breathing. You can see it's coming down his leg here as well. So significant uptake in muscle on his initial scan. They repeated the study 1 week later, making sure that the patient was not on insulin and was fasting. And now you can see that there's actually a lesion up in here that we couldn't really see on the initial scan because of all this surrounding muscle activity. So again, just an example of how proper patient preparation is key to ensuring that we don't miss some of these small lesions. Here's an example of metformin. So metformin can cause significant FDG uptake in the colon, right? As you can see here, right? You can make up the entire bowel. And this is particularly problematic in patients that present with colorectal cancer, right? Because it's almost impossible to know, is this just because of the metformin, or are there actually lesions within the bowel? So this is obviously comes down to proper patient preparation. Metformin is also problematic for patients that may need CT contrast, particularly if they have reduced GFR. So patients that have renal failure, whether it be acute or chronic, the renal clearance of metformin would be decreased. And so there's an associated risk of lactic acidosis. And lactic acidosis has a mortality rate of up to 50%. So it's not something to take lightly. Some patients who receive IV contrast may also experience a deterioration of their renal function. And this is known as contrast-induced nephropathy. And this can also lead to contrast-induced renal failure. So we need to reassess the GFR after CT contrast has been given, particularly before allowing the patient to continue taking their metformin. So something to remember. Okay, so those are the common reasons for false negatives. What about false positives? So when a patient either exercises, or if they're shivering, or if they have a lot of muscular tension, this can lead to increased FDG uptake as a result of metabolic demands on the muscles, and possibly due to the presence of brown fat in the neck. So how do we prevent this? Well, we make sure that the patient is kept calm, and that they're in a nice warm environment, and that they're comfortable during the uptake period. Okay, so those of you that have been to PET know that they keep the patient in a nice quiet room. They've got warm blankets, and you know, they may restrict use of the phone. They tell them not to exercise. You know, it's funny how patients that are trying to you know, make changes in terms of healthy lifestyle, they think, oh, I've got an hour to spare. I'm just going to do some squats, some push-ups and things like that, and make use of the time. So we definitely don't want them doing that. For patients that may be anxious, nervous, maybe a little frightened, so claustrophobic, it may be worthwhile to offer them muscle relaxants. And this can be in the form of diazepam, right, which is Valium. Another agent is lorazepam, which is Ativan. And these can be administered just before the injection to help reduce anxiety. And this will minimize brown fat and muscle uptake. Just be aware that, you know, these are medications, and depending on your department protocol, it may require nursing care and follow-up. There's also been some evidence recently about the benefits of giving low-dose beta blockers to PET patients to try and reduce brown fat uptake. So I don't know that this is being utilized at BC Cancer, but there's been reports in the literature that this is helpful. So here's an example of muscle uptake. Sorry, you can't maybe see it quite so well with my screen here. But this patient here has some muscle uptake in the lower extremities. So this patient, it must have been leg day at the gym. This patient's got a lot of uptake in their upper extremities. So it must have been arm day on the day this patient came in. So generally speaking, we want them to avoid strenuous exercise, certainly on the day of the scan. Some places are even saying, you know, the day before to not do any strenuous exercise, and certainly during the uptake period, you don't want them doing any exercise. We can also get muscle uptake, as you see here. this was in a patient that was had persistent and intense coughing, probably like me if I did a scan these days with the poor air quality. So you get all this uptake in the neck muscles. This can also be seen in patients that are grinding their teeth, chewing gum, right? You see uptake in the jaw in patients that are chewing gum, even fidgeting, right? Has been shown to increase muscle uptake in the hands and the lower arms. Sometimes it's unavoidable, right? So in the case of a patient where maybe they were injected and then they somehow developed a coughing fit, and then you saw this uptake on the scan, there's not much we can do to prevent that. So if that does happen, you should document that on the requisition so that the doctor is aware. Here's an example of insulin-induced muscle uptake. So again, you can see areas where the red arrows are. This is due to high insulin levels. Note that this has a very similar appearance to a patient that has been doing strenuous exercise, right? So again, history is important to differentiate what has caused this uptake. So brown fat is, we could get uptake in brown fat. It's one of the most common sort of false positives that we see. It's usually due to an anxiety or the patient shivering. If they get cold, right, then the brown fat gets activated. So again, keeping the patient warm with blankets will hopefully alleviate this uptake in the brown fat. Just to note that brown fat is also known as USA fat, and that's not a slur on the Americans being overweight. It stands for uptake in the supraclavicular area. Okay, so USA fat or brown fat, referring to the same phenomenon. So again, more physiologic uptake of brown fat, right? And you can see on this the fused image that confirms the location. Because sometimes it's hard to know exactly where is this? Is it in a node? Is it in the cervical node, or is it actually in brown fat? So the fused images can be helpful in that regard. Just a note that obviously uptake in brown fat can interfere with our ability to adequately evaluate patients, particularly with involvement of the head and neck regions, right? So we try to avoid it as much as possible. Here's a false positive with uptake in the patient's larynx. And this was found in a patient that was talking both during and after the injection. So the chatty Cathys of the world, you want to make sure you let them ask all their questions before the injection, and then ask them to try to refrain from talking during the uptake period. Just to note that this patient also has activity due to they had lung cancer and COPD. So there's diaphragmatic activity as well. And this was thought to be due to labored breathing. We can also get false positives in cases of infection and inflammation. So the macrophages, the neutrophils, the fibroblasts, the granulation tissue, they all can show increased FDG uptake. right? And these are all involved with the inflammatory response, and therefore we can see uptake in these areas on our scan. So it is important to check patient history if you see uptake in these areas to see whether or not there is a history of infections or inflammatory processes, including granulomatous diseases, abscesses, even something like thyroiditis. If the patient is relatively early on post-surgical, there may be healing going on in the surgical wounds, scars, stomas. If they have a tube placement or drains, we may see uptake in those areas. And then there can be changes due to radiation. So there can be fibrosis, there can be radiation pneumonitis in the lungs, and all of these are due to inflammation and can cause increased uptake in the lung area and cause a false positive result. So again, important that we have a good history and we know what types of procedures and tests and symptoms that the patients are experiencing. If any of these scenarios come up, you may not be able to avoid uptake in these areas, right? I mean, obviously, if a patient's had radiation, there's not anything we can do about it other than, delay the scan for a significant period of time. So again, just make sure that you document the patient's history on the requisition so that the physician's aware. Here's an example, another one of inflammation. This patient had inflammation of the pleura, lungs, and you can see it's got uptake, quite intense uptake on the FDG study. Healing wounds. So this patient had some kind of abdominal surgery and had a PET scan shortly thereafter, and you can see this uptake in the area of the surgical wound where healing is occurring. Infections. This was a 68-year-old male, and he had a CT that showed a suspicious solitary lung nodule. So they were worried that it might be malignant. Sent up for a PET scan, and sure enough, that lesion lit up, right? And they were concerned that this might be a lung carcinoma, but they ended up biopsying it, which they would do if they suspected malignancy. And it actually turned out to be aspergillosis, which is just a fungal infection. And because it is an infection, it took up the FDG. Okay, so again, sometimes we can get fooled and we end up with false positives. Okay, so the last few slides are dedicated to learning about a relatively new tracer that is predicted to change the way that we diagnose and treat prostate cancer. And there are some predictions that this is going to be what saves nuclear medicine. The sheer numbers of patients that are going to be needing to be scanned and treated, they say is going to keep nuclear medicine techs employed for many years to come. So yet to be seen, but we shall follow up. So this is gallium-68 PSMA. There are some relatively new SNMM guidelines published in 2017 that you can look up if you ever have to do one of these scans. So gallium-68 is obtained from milking a germanium-68 gallium-68 generator. It has a half-life of 67.6 minutes with 89% decay by positron emission. So it's got a relatively short half-life, shorter than FDG. This may be a little bit problematic, obviously, because that means we have to scan them fairly early on. We routinely would scan at about 1 hour. You can probably do up to 3 to 4 hour delays, but be aware that they may be count poor because of the significant radioactive decay. The dose is weight-based, 1.8 to 2.2 megabecquerels per kilogram. As I said, patients injected, and then the imaging is performed 60 minutes later. According to current AUC, so AUC means appropriate use criteria. These are guidelines that are set out for medical professionals to know, which tests are have the best evidence for accuracy and sensitivity specificity. So according to the current AUCs, gallium-68 PSMA is used mainly for imaging primary and recurrent prostate cancer. There are some future applications which may include staging before and after radiotherapy in patients with metastatic CRPC. So CRPC is castration-resistant prostate cancer. We may also be able to use it to provide targeted biopsy after negative biopsy in patients with a high suspicion of prostate cancer. So this is when they might go in and put a needle in and try to get a tissue sample in order to determine, if a patient has prostate cancer. But if they don't get the needle in the right place, the biopsy may come back negative. And yet the patient obviously has a high suspicion of prostate cancer. So imaging with gallium PSMA may help guide the biopsy needle to ensure that it's being inserted into an area that has active disease. And then another potential application would be for monitoring a systemic treatment in patients with metastatic prostate cancer. So looking for bone mets. So a similar application as how we use FDG, but remember that prostate cancer is not particularly FDG avid, but perhaps we can use gallium-68 PSMA instead. This is just an example of a protocol for gallium-68 PSMA. You do not need to memorize this. It's just to give you an idea of how the test is done. Okay? So again, there are, sometimes they give furosemide to try and wash out the kidneys to improve the image quality, and then the typical sort of eyes to thighs protocol. So here's some images. This is a normal scan. It's a pretty nice quality. You'll notice that we get some lacrimal and salivary gland uptake. We get uptake in the liver and the spleen, lots in the kidneys, some in the bladder, or sorry, bladder's down here, and then this is bowel. So this is normal biodistribution. The other three images show positive scans in patients with metastatic prostate cancer. So you can see some uptick here in the right ileum. Here's a patient that probably has some retroperitoneal nodes. And then unfortunately in this fellow here, it's spread throughout the bones. And, if we were to do our regular MDP bone scan, this might be, an example of a super scan that we might see. This slide's a little bit busy, but it just shows how valuable PSMA may be in monitoring treatment response, as well as its ability to accurately identify residual disease. So in the first set of images here, this is a patient, this is FDG, and then roughly 6 weeks later, the patient had a sodium fluoride bone scan, right? And you can see that in this case, the sodium fluoride bone scan was actually more sensitive than FDG in picking up the various bone mets. The second case here, second and third case, I believe are the same patient. So again, FDG done here. A couple days later, the sodium fluoride PET scan was done, and then the PSMA study was also done. And in this case, the sodium fluoride PET scan, the bone scan, was probably superior to the PSMA study in assessing treatment response, right? Or sorry, the sodium fluoride was better than the FDG in evaluating treatment response. Okay, right? So you're seeing more lesions here than we did on the FDG. However, they felt that the PSMA study was superior to both studies in that it was better able to demonstrate the amount of residual disease, right? As you can see, there's still a number of positive lesions on the PSMA that really are not clearly delineated on either the FDG or the sodium fluoride images. So there's a lot of buzz about the use of PSMA in patients with prostate cancer. So we'll just have to wait and see. But so far, it seems to be receiving rave reviews. This is just a review chart taken from an article in the JNM, just comparing gallium-68 to fluorine-18, either in the form of FDG or the DCF-PYL agent, just showing you some of the key differences between gallium-68 and fluorine-18. Probably the most significant one is that gallium comes from a generator, right? Whereas fluorine-18, you require an on-site cyclotron, right? So this may be better for, more departments that could afford perhaps to buy the gallium-68 generator and be able to do gallium-68 PET versus, the $1 million outlay for building a cyclotron. And again, just a comparison here. So DCF-PYL is sort of the fluorine-18 equivalent of gallium-67 PSMA. And in this diagram here, you can see that the fluorine-18 agent actually seems to identify more of the PSMA avid lesions than gallium-68, right? So you can see this very tiny lesion right here, right? And a couple of them up in here, right? Very small, very subtle lesions. Whereas on the gallium-68, now that we know that it's there, we can sort of imagine this one here and maybe this one, but I think you'd be hard pressed to identify anything up in here or even in here, even though they're clearly seen on the fluorine-18 image. The fluorine-18, you can see, has a little bit lower body background, which may increase the target to non-target ratio. The fluorine 18 perhaps has a little bit better imaging characteristics than the gallium 68 PSMA. So it'll be interesting to see, if one or both of these agents sort of clearly comes out as the agent of choice. But it's nice to have some options. So just to finish up, the future of PET in oncology, as you know, PET is a rapidly evolving area in nuclear medicine. There's changes in instrumentation technology all the time, new image reconstruction processing algorithms, software developments, a number of new PET radiopharmaceuticals, lots of research and clinical trials going on. And although we spend most of our time doing oncology applications here in BC, it's hoped that as the numbers of PET scanners increases and resources maybe are freed up, that perhaps we'll see more applications in the fields of cardiology and neurology. In terms of the instrumentation, again, the newer PET-CT scanners are just coming out with better and better resolution. There's also, the introduction of PET-MRI, which, a couple of years ago was sort of, they kept saying, oh, it can't be done, and yet it has been. While we don't have a clinical PET MRI in BC at this point in time, I believe the UBC Brain Research Group were trying to fund research PET MR. I'm not sure if they've been successful yet. Of course, BC Children's would love to have a PET MR because it has all the benefits of PET CT without the radiation. But the cameras are extremely expensive. Actually, Dr. Nadell, who was the nuclear medicine physician at Children's Hospital for 35 years, the reason she left was to go down to LA, to Stanford, to the pediatric hospital down there, because they actually had a PET MR unit. So it's on our wish list, but I'm not sure how long it's going to take before we actually have a clinical PET MR in BC. One of the newest innovations, though, it has been the introduction of the first whole body PET CT scanner. You can go on this link here and see a video of it, but it's pretty cool, right? You get a whole body PET in just one bed movement. And of course it can do SPECT. Well, not SPECT, I guess it's PET, but can do the cine, which is pretty cool. If you go on to this website, you can see this. So as I say, this was revealed at the SNMMI in June. In terms of instrumentation and software, we're going to have shorter scan times, hopefully lower doses, and advanced reconstruction algorithms that will improve our image quality. There is definitely proven clinical usefulness of PET CT, right? We know that it provides a more accurate diagnosis, can, in the process of that, reduce the number of unnecessary tests, may help patients avoid more invasive procedures. And as I said, it leads to changes in treatment or patient management, whether that's because we upstage the patient and are able to identify progression of disease and metastatic spread, which would convince both patients and physicians perhaps to abandon a certain type of treatment, or whether it downstages the patient so that they become eligible for certain types of treatment. And as I said, there's evidence that PET CT leads to changes in patient outcome in about 30% of patients, which is a huge number. So research continues to investigate new tumor types that will benefit from current and new PET tracers. And research is also rapidly advancing in the area of theranostics. So you may have heard of lutetium-177, which is a beta emitter that may be able to be used for peptide receptor radiation therapy, for neuroendocrine tumors, and also to do palliative bone. So we'll talk a bit more about these, and we'll do some case studies in class to test your knowledge. All right, so I hope you enjoyed that, and hopefully that's going to be helpful to you when you do your PET rotations. And that's the end of the PET unit. Tuning out for now. See you.